Okay. Good evening in India, good morning in Americas, and of course good afternoon in Europe. Welcome to this webinar on advances in metabolic and bariatric endoscopy, co-organized by the Mayo Care Clinic Network and the AIG Hospitals, Hyderabad, India. I am Nageshwar Reddy. I work at the AIG Hospitals and like to welcome you to this webinar. Also like to thank Barham and Rakesh for making this possible. In the recent years, I think the most dramatic advances in GI endoscopy have occurred in the field of bariatric and metabolic endoscopy. Many of these procedures are now becoming a standard of care and are competing and replacing bariatric surgery in many areas. This evening, to discuss many of these advances, we have the world's leaders in this field. We are fortunate to have people who have actually described many of these techniques for the first time, have repeatedly published in this area, and are going to give us the distilled wisdom of what's happening in this area. The plan this evening is that we'll have these 5 talks in different areas of 15 minutes each, followed by Q&A for another 15 minutes. So if you have any questions, I request you to all put it up. We have a channel to get your questions and then we can discuss it with the panelists. Our first speaker this evening here is going to be Professor Barham Abudeh. Barham is Professor of Gastroenterology, is the Director of the Metabolic and Bariatric Endoscopy and a consultant and in charge of Advanced Therapeutic Endoscopy at Mayo Clinic in Rochester, USA. He is not only a true pioneer but an outstanding endoscopist and teacher, and we are fortunate that he is here with us to talk this evening on endoscopic, bariatric and metabolic therapy from the prism of a personalized medicine. Barham, thank you and welcome.
Thank you, Nagi. I appreciate the opportunity. Thank you for an awesome organization. Rakesh, thank you for all your hard work. I will be sharing my screen. All right. So we're going to talk today about an important topic, which is how do we look at physiology to help us select and personalize the choice of the treatment to the physiology of the patient. I'm going to share with you evidence that shows the importance of this concept, and really it will break down a lot of the assumptions that we have about bariatric surgery, endoscopy, and the role of the gastrointestinal tract in the therapeutic capability to treating the disorder of obesity and metabolic disease. So I like to start with this slide to level set what do we have currently and where do we hope to go in the future. So currently we have a spectrum of interventions that spans the gamut of efficacy and also tolerability and safety. In the field of endoscopy so far, we've done okay, but we're still stuck in this zone of 5 to 10% total body weight loss with most of the implantable devices. Though they are safer than bariatric surgery and more accepted because their anatomy preserving nature, they still are associated with some intolerance and safety issues as well. So that's where we are, and where we're hoping to go is in this circle where we're going to have therapeutic options that are minimally invasive, anatomy preserving, but at a closer efficacy to bariatric surgery with more adaptability and acceptance by the patient and less risks and cost. So we're hoping to operate within this circle by using this personalized approach to these procedures and interventions. I'm going to start with a study done in rats, published in eBiomedicine in the Lancet, and because I think it demonstrates a very cool concept. So our gold standard metabolic and bariatric procedure currently is the Roux-en-Y gastric bypass. And what does the Roux-en-Y gastric bypass do? It decreases the gastric reservoir. It excludes the proximal small intestines, which we think plays an important role in reversing insulin resistance. and then it introduces partially digested food to the distal small intestines, thus causing an incretin effect through different hormones like GLP-1 and PYY. So these investigators said, okay, we have these components of the gastric bypass. Can we test a device which restricts the gastric reservoir by creating a small pouch and bypasses the proximal small intestines in a similar fashion at your gastric bypass? So they did this in a very rigorous, randomized, controlled fashion and compared it to a sham procedure. The interesting part is, if compared to a sham procedure, both this balloon sleeve combo and gastric bypass had significant similar reduction in body weight, significant and similar reduction in visceral adiposity. If you look at the graphs for the blood glucose, you could see compared to sham that they both significantly reduced blood glucose. And if you look at the insulin curves, you could see that the sleeve balloon combo had an attenuated insulin response. That means post-meal, the insulin did not peak. And if you look at the area under the curve, it's much less than the sham. And the gastric bypass had an early peak in insulin, but then a quick return to normal and below normal or below sham levels afterwards. If you look at the GLP-1, that they both had a similar peaks in GLP-1. So if I'm looking at this picture, I'm seeing two interventions. One is endoscopic, that combines a balloon with an endobarrier or a liner to bypass the small intestines. And the other one is the gastric bypass. On the surface, they look to have, at least in rats, similar efficacy and similar physiology. But what I'm going to show you here is they both reached to these outcomes, to these important metabolic outcomes, in a different physiological manners. So here they also did staining for fats, and you could see these red droplets in sham. This is oil droplets that stain as the fat staining in this red dye. And you could see after the gastric bypass, both in the liver and skeleton muscle, and with both the gastric bypass and the sleeve balloon combo, that there was almost resolution of ectopic fat from the liver and skeleton muscle. Again, both performing similarly. But what's the interesting part is, I just told you, they both got there through completely different physiological pathway. So the authors in the study, they looked at the emptying or the transit time of the gastrointestinal tract. So in the top panel, they looked at the sleeve balloon combo, and they looked at the emptying of a labeled meal at 5 minutes and 120 minutes after the intervention. You could see at 5 minutes, most of this food in the sleeve balloon combo is sitting in the fundus, and very little has emptied to the small intestines. And at 120 minutes, still the majority of the food is still sitting in the fundus, and very little has emptied to the distal small intestines as well. So there is a significant delay in gastric emptying with this sleeve balloon combo compared to the sham in the lowest panel. Now, what happens to the gastric bypass? You could see that there is a rapid emptying. There's a quick emptying of the entire content to the distal small intestines. So I just showed you that we have two procedures that had identical resolution of ectopic fat, reduction in body weight, and physiological response, but they both got to there in a different pathways, one by delaying gastric emptying and the other one by speeding gastric emptying. So that concept leads me to think that there is multiple pathways that we could use in order to match the procedure to the patient physiology in order to maximize the outcomes. By the way, we just published this in Clinical Gastro and Hepatology, and we did this FDA pilot study where we looked at the impact of the intragastric balloon that delays gastric emptying on all these metabolic and liver fat content. And similar to what they observed in rodents, you could see that the percent fat fraction on MRI after the intragastric balloon in the liver has decreased by almost 80%. But there's also significant evidence to show that the balloon, by delaying gastric emptying, reduces the hemoglobin A1C by 1.3 points and reduce ectopic fat significantly on histology and on MR PDFF fraction. So then, to extend this concept from rodents to humans, we also published this systematic review and meta-analysis in CGH that we looked at all the physiological data out there, and we wanted to correlate changes in the gastrointestinal transit time with the weight loss effect of the intervention. So here we looked at changes associated with the intragastric balloon, and you could see with the intragastric balloon, the more that you delay the gastric emptying, as you see in the x-axis, the more the effect of weight loss at 6 months after the balloon. In this opposite graph, we looked at sleeve gastrectomy that speeds the gastric emptying, and now you have the reverse effect. With sleeve gastrectomy, the more rapid the gastric emptying, the more the weight loss that happens. So that corroborates what we saw from this important rodent experiment, that it's delaying gastric emptying or acceleration in gastric emptying gets you the metabolic and weight effects that you're looking for in the cohort that you are treating, and this is data from humans to corroborate this concept. So how to choose? We have devices that would delay gastric emptying, devices that would bypass small intestines, devices that ablate small intestines, device that speeds gastric emptying, and now we have this soup of devices, or a salad of devices, sorry, that we have to offer to our patient. And how do we offer it to our patients? In my opinion, the way we offer it is based on the physiology of that patient. That means not all patients are created equal, and some patients, their obesity phenotype is driven by a different determinant, and we should match the device or the endoscopic intervention to the physiological phenotype of the patient. And that graph here is to illustrate that key point here. So this is about 260 patients who came to us asking for a bariatric intervention for their obesity. We phenotype them at baseline. That means we measured their gastric emptying at baseline. And what I'm presenting is the percent gastric retention at 2 hours on the x-axis. You could see that some people are very rapid emptiers, others are very slow emptiers at baseline, and there's the in-between. So to me, it never made sense to say that all of these individuals that are physiologically quite different will respond similarly to the same intervention that we're going to give them. So how do we take this heterogeneous cohort of individuals with obesity and now segment them to match their physiology to the device that we're offering to optimize the outcomes and minimize the risk? So we all know that one of the major mechanism of actions of intragastric balloon is a delay in gastric emptying. This was proven conclusively during the FDA trials of this device, where we looked at the effect of the gastric balloon compared to a control, and you could see that compared to a control, that the gastric balloon significantly delays the gastric emptying. Once you remove the balloon, the delay in gastric emptying reverses back to normal. So with collaboration with Professor Lopez Nava and the team, we said, okay, let's try to apply this personalized endoscopic bariatric and metabolic choice to a prospective feasibility study using the single fluid filled intragastric balloon. So we took 32 individuals and we classified them at baseline using their gastric emptying. And then we took those who are at baseline with delayed gastric emptying. That was about eighth of the cohort, or a quarter of the cohort. And we said, the balloon delays gastric emptying. You already have delayed gastric emptying at baseline. You will unlikely respond to the balloon, and you would likely have intolerance of the balloon. And that's exactly what we observed. We observed that when we gave this cohort the balloon, that about 2/3 of them required early removal of the balloon because of intolerance. So if at the beginning you said this cohort is not a candidate for a gastric balloon, you could have avoided this early removal from intolerance. Then if you looked at the remaining 24 that were normal to rapid emptiers at baseline, you gave them the balloon, there still were two cohorts. There's a cohort that in the response to the balloon, which the majority of the cohort had significant delay in the gastric emptying, and this cohort actually lost a lot of weight. But there's a cohort that did not delay the gastric emptying at all in response to the balloon, and this cohort did not lose a lot of weight, and this cohort would have benefited from an adjunct modality to augment the weight loss with the intragastric balloon. So what this pilot study showed us, that we could use physiology at baseline to select patients for tolerance and safety, and to marry the device to the physiology, but also the response of the physiology or the response in the physiology to the device could also predict response in the hard outcomes like weight loss and metabolic improvements. And as such, we could now intensify adjunct therapies in order to maximize the weight loss based on the physiological response to the device. So now we have the devices or the group of procedures that gained a lot of tractions with patients because they're tolerated, they're safe, and they're anatomy preserving, but that does not have an implantable device, is these gastric remodeling techniques. So let's see how we could take this concept of physiology and apply it to the two evolving and now becoming popular choices to use gastric remodeling for the treatment of obesity and metabolic disease. On the one end, there is the endoscopic sleeve gastroplasty, and on the other end, there's the POSE 2.0 procedure. They both work by reducing the greater curvature of the stomach, but now I'm going to show you evidence that though they look a little bit similar based on anatomy, they have a different physiological response that we could capitalize on to better select the patient for response and tolerance of the procedure. So let's look at the endoscopic sleeve gastroplasty. You could see that you take the stomach before, these are courtesy from Manuel Galbao, and you could see that you tubularize the greater curvature of the stomach, thus reducing its capacity and its diameter. This is an MRI image of the endoscopic sleeve gastroplasty. You could see the tubularized stomach, and you could see the takedown of the greater curvatures of the stomach with the emptying of the stomach. Now, we are in the midst or just finishing the MERIT trial. And in the MERIT trial, it was the perfect opportunity to study the physiology of ESG in a large cohort. So here you could see the effect of the endoscopic sleeve gastroplasty on gastric emptying of the stomach. And you could see here is the control arms, and that y-axis is the time to have emptying. And what you're seeing here is in the control, at 3 months and 12 months, there was not much delay in the gastric emptying. With the endoscopic sleeve gastroplasty, you could see that at 3 months, there was almost doubling of the time to empty half of the meal. So there was significant delay in gastric emptying. And what's interesting is the physiology was maintained at 12 months after. So even at 12 months after, there was continued significant delay in gastric emptying. So we concluded that endoscopic sleeve gastroplasty works, in part at least, by delaying gastric emptying, and this delay in gastric emptying is more durable than with the implantable devices like the intragastric balloons. So now what about this POSE 2.0 procedure that uses these plications that plicate the gastric wall by creating these pinches in the gastric wall? The concept with this procedure now is not only to tubularize or reduces the stomach, but in essence, it's also significantly crushing or reducing the length of the stomach, creating, to our surprise, a slightly different physiology. than the endoscopic sleeve gastroplasty. So this is the concept of this post 2.0 procedure. And here you could see that we're using this GPROX in order to acquire the entire gastric wall and introduce the 7-centimeter plication into the gastric wall. We do this in a sequenced fashion, starting at the level of the greater curvature opposite to the incisura, and then marching all the way to the junction between the fundus and the body of the stomach. And you could see that this is the eventual effect that you will encounter with this procedure. I think I'm looking at there's a slight delay in what I'm speaking and what you guys are seeing probably. So keep that in mind when I discuss, because I'm looking at both screens here. So in essence, then, what you're seeing with the post 2 is a significant longitudinal reduction in the length of the stomach on top of this tubularization of the greater curvature that seems to be also accelerating gastric emptying, not just delaying it, as the case with the endoscopic sleeve gastroplasty. So if you look at the stomach, this is an ex vivo stomach before. The stomach here is large, and this is the stomach after the procedure. So we end up going from, if I could give you an analogy using a can of Coca-Cola, you go from a can of Coca-Cola to a crushed can of Coca-Cola here, where the fundus is almost touching the antrum because of the decrease or the accordion effect of the procedure on the gastric physiology. These are images from the gastrographin study that was done before and after the procedure, and also you could see here the endoscopic pictures, and again you could see this accordion and significant reduction in the longitudinal length of the stomach that we've been seeing with the gastric with this post 2.0 procedure. So if you count with me here, if we go from the fundus before all the way to the incisura, it is about 1, 2, 3, 4, about 5 vertebral bodies to get the length between the fundal cap and the antrum of the stomach. If you look at after this post 2.0 procedure, the length between the fundus cap and the antrum of the stomach now is reduced to about 2.5 vertebral length, as you could see in endoscopy. Thus, this seems to be accelerating gastric emptying more so than delaying it, like we see with the endoscopic sleeve gastroplasty. So we have two procedures that are very effective, but one seems to delay and the other seems to accelerate gastric emptying. So now we could use this to our advantage to better select patients for this procedure or the other in order to enhance the efficacy and durability and metabolic effects of these procedures. So if you look with me here, this is a part of the FDA study in the US with the post 2.0 procedure. We did a gastrographin studies or a timed gastrographin studies before and after the intervention. So before the intervention, when you give a timed gastrographin study, you could see that the majority of the gastrographin is sitting in the fundus of the stomach, and little has emptied to the small intestines of the after that. If we look at after the intervention, you could see that at the time sequence that the stomach is shrunken. So now it's 2.5 vertebral bodies in length, and most of the gastrographin has emptied to the small intestine pretty quickly. Again, showing now that we have two procedures that remodel the stomach. One could potentially delay, and the other one could potentially accelerate gastric emptying. And if we look actually this is the study that we've done as a multi-center study with Gontrad Lopez-Nava, with Teknon and Roman Turo in Madrid and in Barcelona, and with the collaboration with Manuel Galbao. It was a 3-center study, 2 in Spain, 1 in the US, based on an FDA study that looked at this POSE 2.0 procedure. So you could see again that there's significant reduction in weight loss, but that Dr. Lopez-Nava will discuss that more. But what I wanted to emphasize to you, that when you looked at predictors for this weight loss, I just showed you the endoscopic sleeve gastroplasty, the predictors of the weight loss was the delay in gastric emptying. Now when we look at the predictors of weight loss with the POSE 2.0 procedure, you could see that your likelihood of achieving more than 15% total body weight loss at 12 months is determined by the acceleration on the gastric emptying at 3 months. So now we're having 2 procedures really that, again, I'm sounding like a broken record, but 2 very effective, very appealing procedures that works slightly on different physiology, that we could use this to our advantage. So I will conclude here with illustrating how this future is gonna look like. And I'm gonna quote one of my brilliant colleagues, Dr. Andres Acosta here, in the work that he's been doing along these lines. Andres is trying to break down the phenotypes of obesity into what's driving that phenotype. And one of the drivers for obesity here is this concept of a hungry gut, okay? So if you look at this subset of the obese individuals, and one of the phenotypes is this hungry gut, and you could break down this hungry gut into the baseline gastric emptying of this phenotype, and you could see now that this cohort could be divided into those with accelerated gastric emptying at baseline, and those with delayed to normal gastric emptying at baseline. So you, again, now we could go and segment this population, and those with accelerated gastric emptying at baseline could be offered a fluid-filled intragastric balloon or endoscopic sleeve gastroplasty, and those with delayed or normal gastric emptying at baseline could be offered either an endoscopic sleeve gastroplasty or a POSE 2.0 procedure, because that makes sense based on the physiology that I alluded to, starting from rodents, confirming it in humans, and now bringing it back to endoscopic bariatric procedure. I think the era of personalized choices is upon us. We're pushing this envelope to be operating in the high efficacy, low risk zone of obesity intervention. And I think one of the things that would propel us to get there is, now we have durable procedures. Now we need to marry the procedure to the physiology of the patient in order to get there. Thank you for the kind attention. I apologize, it seems there is delay between what I'm speaking or showing and what you are seeing, but hopefully I slowed down enough to give you the gist of what I'm talking about. Thank you so much.
Thank you, Barham, for that very thoughtful, brilliant lecture on personalized medicine in this area. I think many new concepts that you have told us. So we'll take the Q&A at the end, but our next speaker is going to be Professor Reem Sahara. Reem Sahara is the Assistant Professor of Medicine at the Weill Cornell Medical School and University at New York. She is, of course, very skillful, advanced endoscopist. She is also published extensively in this area. And Reem is going to tell us what we missed at the DDW this year. Reem, thank you for coming.
Thank you again for having me, and thank you so much for the invitation. So I have a somewhat easier topic than the rest of the group. It's basically what we missed at DDW, and I hope I give all the authors and researchers their due respect. So to look at all the DDW abstracts, you basically go to ddw.org, and I did a quick search on either obesity or metabolic abstracts, and what came up is around 306 obesity abstracts, similar number with metabolic. And I narrowed them down for this talk to 9 abstracts, 5 on primary endoscopic treatments and 4 on revisionary. And a lot of this, a lot of the authors are on my panel today, and some of the talks you'll hear in a little bit more detail as you did with Barham. So pose 2, which Barham just talked about, is the sort of belt and suspenders approach, where you imbricate the stomach using the pose device. This was a multi-center study with 41 patients. They had a total body weight loss of 17% at 9 months, and about 91% of their subjects achieved 10% or more of total body weight loss. And you saw what Barham described, how the procedure works, so I won't belabor the point. But what was interesting is that they had no significant adverse events. They had improvement in elastography, which corresponded to an improvement in ALT, sort of suggesting that there's a role in hepatic steatosis. Furthermore, when they looked at the satiety and satiation scores, you can see baseline in red, and at 2 months and 6 months, you can see significant improvement in the satiation and satiety scores, and they looked at impact of quality of life with also significant improvement. So the conclusion for this study is that POST 2 is a novel, safe, and effective endoscopic bariatric metabolic study with midterm response approaching the response rate of bariatric surgery. And it's also durable. They scoped people at 6 months showing intact sutures. Next is the endoscopic European suturing registry using the Apollo overstitch device. They enrolled over 800 patients, and Lopez Nava is the main author on this, with 700 or so ESGs, 36 tours between January 2018 and November 2019. The mean age of this was 44, mean BMI was 36. What was interesting, though, with this registry is that they looked at the different suturing patterns, which I thought was interesting, V pattern, Z pattern versus U pattern of the endoscopic sleeve. And what they found was that at the 12-month mark, you can see that the weight loss was statistically significantly different between the different patterns, sort of U pattern having the most significant weight loss at 21% total body weight loss compared to the others. And about 93% of their subjects achieving more than 10% total body weight loss, which we deem as significant for metabolic outcomes in endoscopic therapies. So the conclusion of this abstract was that the registry highlights that ESG is a safe and effective weight loss procedure, and that the suture pattern may influence greater weight loss. So further prospective studies are needed, but this is a great study to show that. Next, there was a study actually done from our institution showing the improvement in quality of life and mental health and weight loss outcomes following endoscopic sleeve gastroplasty. So we took 50 patients at baseline and at 1 year post-procedure. And what you can see is that there's improvement in the SF-36 score, depression screening, and satisfaction between the groups, and that the more you have weight loss, the better the scores. So the conclusion of this abstract was that ESG was associated with improvement in quality of life and mental health, and there's continuous association between total body weight loss and ESG and improvement in their mental health and physical health quality of life scores. Next was a meta-analysis that came out of the Mayo group, looking at the efficacy and safety of the procedure-less balloon. So this is the ellipse balloon, which basically is inserted via an NG tube mechanism, and it's attached to a saline bag with proprietary solution that inflates the bag and after 4 months, the sutures inside the valve dissolve and the balloon passes through the GI system. We just completed the FDA trial, but this was done before the FDA trial data. They had 160 studies with 6 unique studies that they included. Their main BMI ranged from 30 to 36. Adverse events included 3 patients with small bowel obstruction, which either required endoscopic or laparoscopic removal. It's important to note that since then, the company changed the design of their valve, and in the FDA trial, they had no such adverse events. In terms of total body weight loss, you can see that the average total body weight loss at 4 to 6 months is about 12%, which is similar to the other saline filled balloons. And their conclusion was that this meta-analysis demonstrates that the ellipse balloon is a safe device offering effective weight loss. The serious adverse event rates are 0.2%, which are rare. And we're awaiting, obviously, the FDA results for the US trial that's going to be presented at the obesity meeting this October. So this was another study that came out of the Brazil group with Manuel's data, and it basically shows that ESG plus liraglutide is superior to ESG alone. And I thought this was interesting because there's been a lot of talk on combination therapy of procedures. So you think of bariatric procedures as a procedure that offers a tool for patients, but if that doesn't work, you may need to augment it with certain medications. So this was obviously a study where liraglutide was offered to patients post-ESG, so it wasn't randomized, so it was patients that sought more weight loss. And what they saw is that the liraglutide group compared to no liraglutide had a significantly more weight loss. But if you look at the weight loss with ESG alone, it was still pretty good. It was at 20%. So you're talking between 20% total body weight loss versus 25%. But it's an interesting concept. Finally, moving on from primary therapies, we're talking about revision. So this is patients who regained weight after either a sleeve gastrectomy or a Roux-en-Y gastric bypass. And this is from Cy Pishamol and the Thompson group from the Brigham. They did a personalized algorithm for weight loss in patients who failed therapy in Roux-en-Y gastric bypass. So what was interesting about this design is they looked at the 3 different modalities for reduction of the outlet, either APC or suturing called STOR, or using the posed device called PTOR. And what they found at 1 year, there was significantly more weight loss in the STOR and PTOR group compared to APC. But when they looked at this in sort of a more rigorous manner using sensitivity analysis, what they looked at is that for patients who had more than the pouch that was more than 5 centimeters, they compared the STOR versus the PTOR. And when they looked at it sort of more significantly, looking at the GJ size, the outlet size being more than 3 centimeters or less than 3 centimeters. If the outlet was more than 3 centimeters, the STOR, meaning the suturing group, did better than the plication group with a weight loss of 11% total body weight loss versus 2.7, which was statistically significant. But if the outlet was less than 3 centimeters, then the weight loss was better in the plication group, the pose group, 11% versus 7%, and this was statistically significant. They then looked at the outlets that had pouch size greater than less than 5 centimeters, and when they looked at the diameter of greater than 18 millimeters, the STOR, meaning the suturing group, did better. And if the diameter was less than 18 millimeters, then there was no difference between APC and STOR. So based on these results, they came up with this algorithm looking at pouch size. So if the pouch size is greater than 5 centimeters, then you would either consider doing eSTOR or plication. And based on that, you would basically base it on what the diameter of the gastrojejunal anastomosis. So if it's greater than 3 centimeters, you would use a suturing device. If it's not greater than 3 centimeters, you would use the plication or pose device. And then if you have a pouch size that is less than 5 centimeters, then you would either choose the APC or suturing, and that would depend on the anatomy of the or the size of the gastrojejunal anastomosis. So if it was greater than 18 millimeters, you would use a suturing device, and if it is not, then you would use APC or TOR, but it makes sense to use APC as it's obviously cheaper. Next, moving on to the revision of the laparoscopic sleeve. So we know that there's multiple data using outlet reduction, but what about the sleeve gastrectomy and those that regain weight? We were part of this trial that was headed with the Mayo group, and what you can see here is we use the suturing device following sleeve gastrectomy. And this was over 9 sites with 82 patients. And what you can see here is that the weight loss was significant at each time point. Sort of at 6 months, you had 13% total body weight loss. And at 12 months, the weight loss was 15% total body weight loss. What was more interesting is that you had a good percentage when looking at the percentage responders, either the good responders defined as more than 10%, 72% of the subjects at 6 months and 81% of the subjects at 1 year had more than 10% total body weight loss, versus about 50% had 15% total body weight loss at the 1 year mark. So the conclusion of this abstract was that the revision of ESG for laparoscopic sleeve gastroplasty, laparoscopic sleeve gastrectomy, is safe, effective, and durable. But obviously, larger prospective studies are needed to see who would the procedural and patient factors that predict clinical success. This was a smaller study done from the Brigham group, just looking at 18 patients, 9 with the sleeve and sleeve, which is the endoscopic sleeve of the surgical sleeve gastrectomy, which I just described, versus a surgical revision of the sleeve gastrectomy. And what I want you to notice that even though the surgical group had a slightly higher weight at baseline, that the procedure time was not that much different, although it was time-wise, it was a little bit different between the endoscopic and surgical group. And then when you look at the length of stay, which I think is more important, it was significantly less in the endoscopic group versus the surgical group. And it's important to note that at the Brigham, they admit all their patients, but in a lot of other institutions, both me and Mayo included, we discharge people the same day. So that result will be even more significant. And finally, we looked at the two primary surgical treatments, the Roux-en-Y and the surgical sleeve, but what about the endoscopic sleeve? So this was a study that came out of Spain looking at patients who either who had all primary endoscopic sleeve, but either had weight loss failure, defined as less than 10%, which they had 11 patients in that group, or patients that plateaued and wanted to have more weight loss, or patients that had weight regain after the endoscopic sleeve. And what you can see is that they all had a revision or a redo ESG. And what's more, what was interesting is that they all had significant weight loss. So you can see here that the total body weight loss in all groups were good. They had an additional 5 to 10 kilos in weight loss. But what's more interesting is that the patients that had weight regain had the better outcome. So again, this highlights that revision of ESG is technically feasible and safe to perform after the primary procedure, and the results demonstrate that that the minimally invasive repeat ESG may serve as an additional tool to further enhance weight loss in patients with either weight regain, weight plateau, or weight loss failure after the primary procedure. So I hope I've taken you briefly through a whirlwind of the abstracts out there. The conclusion from all of this is that endoscopic devices are safe and effectively induce weight loss in moderately obese patients. There's been a rise in a lot of endoscopic devices. The FDA has approved 2 devices this year, and hopefully more so later on. More so later on this year and next year. So endoscopy can be used as a way to treat weight regain as part of a comprehensive algorithm. Thank you very much.
Thank you, Reem, for that very nice summary. I think more than 300 abstracts at the DW indicates the interest in this field, which is rapidly growing, and that was summarized very well. Our next speaker is going to be Professor Lopez Nava. Lopez also is very well known. He runs one of the largest centers in Europe in Madrid, Spain. He is the professor of gastroenterology and founder of the Bariatric Endoscopy unit at the San Chiro University Hospital, Madrid, Spain. He is of course an expert in gastric remodeling area and is going to talk to us on new and evolving gastric remodeling techniques. Lopez, thank you. Thank you for being with us.
Thank you very much. Wow, I have a problem. Sorry, I have a problem to connect. Okay. I think a problem sharing the screen. It says deny access to the PowerPoint.
Yeah, I think.
Hi, Dr. Reddy. So thank you for this. I'm sorry for this. Can we jump to another speaker and try to solve why I cannot share?
Sure. So what we'll do is we'll go to our next speaker, who is Rakesh Kal Paulo. Dr. Rakesh is the director of our Bariatric Endoscopy unit at the AIG Hospitals. He's again worked a lot in this area, especially the metabolic endoscopy area, involved with a lot of new devices, and is going to talk to us on novel gastric and small intestinal space occupying devices that are coming in this area. Rakesh, thank you.
Yeah. Thank you, sir. So I thought Gontran will give me a way to the other things, but anyway, so I'll start with this. So what I'm going to talk to you in the next 15 minutes is on the novel gastric and small intestine space occupying devices, which we are right now for kind of doing research on this. So I will be talking only on these intragastric balloons, that is a gastric space occupying devices, and the small bowel space occupying device, that is a bypass liners. So what exactly one has to know about these metabolic therapies is, if you have a gastric space occupying device, then you have a weight loss with metabolic effects. If it is a small bowel space occupying device, you have metabolic effects independent of weight loss. So that is what is the basic principle behind this. So if you see the interventions in the stomach, there are many FDA approved devices, and I won't talk about the gastric remodeling because anyway Lopez is going to give an idea of this. So these are the main gastric space occupying devices, the balloons which have both liquid and air balloons, then the transpyloric shuttle, that is a Baranova, then you have the Aspire Assist, and a new thing that is full sense, which I'll tell you in detail. So more or less we have the liquid and air filled balloons, and the maximum range of total body weight loss is between 6 to 12%, which is consistent with the previous studies. So as you see, the third one, the Obalon, is a new kit in the block, which is a air filled balloon of 250 ml of nitrogen mixed gas is put, and you ingest 3 balloons at every 3 to 4 weeks, and what you see, at the end of 6 months you remove endoscopically. I'll just show you an animation video how it is done. So as you see it on the screen, so this is how the balloon is ingested, and as it goes into the gastric juice inside, it will just open up the capsule, the gelatin capsule opens up, and then it will create a balloon here, and then you just have to pull the tag, it will come out. So this is how it is done, and you ingest 3 balloons, as I told, in a span of around 4 to 8 weeks, and 6 months you will find the results. What have been shown is the excess weight loss of 40% in 3 months. And of course you remove this endoscopically, it won't come out on its own. The another one which I want to show you is what Reem has already shown in the last video. So I can save time by not running the video. So this is again a balloon which has got air which fills it with the air, and then it digests on its own, and then it will, after 6 weeks, it will pass out of the large bowel and get degraded. And what the main thing what I want to tell you, it's a gelatin made balloon which has 450 ml of fluid inside, and it degrades in 6 weeks. The study what she has shown has an excessive weight loss of 12%. The next one is the Sparse balloon. We all know about this, but why I have put this is, now the adjustable Sparse balloon is the one which is the talk of the hour. And the advantage of this is, as you see in the slide, so if the patient, most of the people who have got the balloon ingested, they cannot tolerate, we end up in taking it out. So the advantage of this is, if the patient is not tolerable, then we can take out 50 to 100 ml, or if there is not adequate weight loss at 4 to 6 weeks, we can ingest more 50 to 100 ml. And based on this, as Barham told in his talk, he has, they have did a nice study on the non-adjustable Orbera balloon. So we just started a clinical study with the adjustable Orbera balloon in patients with NASH or NAFLD, and we are trying to see what are the endpoints in terms of fibrosis improvement as well as the other parameters. So this is again a very novel thing which I thought I will just share with you. Gelesis 100 is just a simple capsule made of gelatin. You ingest it inside and it goes into the gastric juice, you eat the food, and the balloon, the material will swell, and then it will decrease the accommodation, so you don't eat more, and as in when you finish the meal, then this degrades and then goes into the small intestine. So this is very novel, and I think probably anybody can practice this, but let's hope how it will evolve in the future. Now the next 3-4 slides, I want to concentrate you all on the main mechanism of the physiology, what happens. See, in the gastric cardia, you have a lot of mechanoreceptors. And the main basis for this, if you have exerted a pressure on the mechanical receptors, that leads to early satiety and satiation. Based on this physiology, what we have done is, it's a full sense is a device which is originated from the Michigan. It's a BFKW group, the company name. So this is alike esophageal stent, but as you see on the screen, what happens is this bariatric stent has got two components. One is the esophageal component, another is a gastric component. And as you see, the esophageal component is made of nitinol mesh, and the gastric disc is the one which will create the pressure on the mechanoreceptors, and that leads to a pressure on the gastric cardia, leading to early satiety and ending up the person not to eat much. So this is how the delivery system is, and as you see here, there are the two pieces which are joined together by a stud, the two wires made of nitinol, and this is a controlled delivery system, very easy to deploy. It just makes maximum of 10 to 15 minutes procedure. Only thing is you have to have a patient on general anesthesia and intubation, and I just show you a short video of how it is put, and thanks to Barham who has made it. This is the first human trial after the modification of device being happening in the world, and we are a part of it. We are the center, we are doing this. As you see on the screen, so this is how the gastric disc is deployed on a retroward position, and this is the capsule which has got the inbuilt device. And once it is deployed, the esophageal part will be sutured or anchored with the Apollo overstitch. So we usually put 3 sutures on the proximal part, and then the distal part is sutured where the stud is coming out with again the Apollo overstitch, and we usually make a figure of 8. So this anchors the device without migrating down, and this is how it is done. And once the suture is placed, so as you see here, the distal part is being placed, and in the next couple of seconds you will see how the device exactly fits into and causes the pressure on the gastric cardia. So this is how it is deployed. So that completes, and you see when you retrovert, it is snugly fit along the cardia, and when you come out, you can see this is the suture at the distal part, and this is the mesh. They have 3-4 rents which eventually will have the tissue overgrowth, which also gives much more anchor, and these are 3 T tags which are on the proximal end. So, and you usually wait for 6 months, and the device also is pretty easy to remove. It again takes 5 minutes, and in fact we did all the cases in our series on conscious sedation when we were removing it. So these are 3 tags on the top upper part, which you just have to cut it. Initially you go down and then you take a forceps or a coa grasper, just cut that strut with the suture there, and that will release the gastric disc from the GE junction. Then you come up using any of the cutter, you just cut the suture of the Apollo overstitch. All the 3 tags are cut, and then you have a lasso with which you can pull the device out. So initially the esophageal part will come out, and then along with the struts you take out the gastric disc. So it hardly takes 5 to 7 minutes for the removal of the thing. So this is just a video, as you see. So this is how we remove. So the initial clinical experience was done in a group of 50 to 60 patients in Mexico, and then there are a lot of modifications in the device, and then before the FDA trial we started doing it, and we are also additionally looking after the diabetes impact on this device. So let's see how it goes. So this is the standard protocol what we use, and we are following up the patients for 12 months, 6 months with implant and 6 months after explanting, and then we are trying to see what happens. The second part of my talk is one which probably everybody is looking forward across the world, the diabesity. So we have diabetes, obesity, and the NAFLD. So what can we do in this? So this is where the interventions on the small bowel happens. And as of now, there is one device which has been taken back by FDA, EndoBarrier, and is again reintroduced. Otherwise, there are not much of devices pertaining to the small bowel. So the basic thing, probably Manoel will give you even more insight on this, the metabolic mode of action. So as we all know, the foregut hypothesis and ileal break. So once you have bypassing the small intestine proximal part, what happens is there will be increased plasma bile acids, and there will be a lot of neurohormonal mechanisms which happen, which leads to increase in the incretins, that is GLP-1 analogs and PYY and so on and so forth. And then there will be decrease in the anti-incretins. The anti-incretins will be dominated by incretins, which is what we want in a physiological manner. So as you see, the EndoBarrier study, it's proved in a very elegant manner that it has an effect on the diabetes with decrease in the HbA1c levels, as well as on the weight loss. But unfortunately, because of some adverse effects, it has been recalled back, and now I believe the FDA has reapproved it, and then it's come back. So putting this in the background, what we thought is, let's go for a next generation solution, and that is where the endosleeve picture has come into the concept. And this is actually a device from a company called Metabolomics, which is based out of Minneapolis. And this is a very simple device. We have a very good first human trial has been done with our group. And as you see here, the animation video initially, which shows a very simple way of deploying the device. It hardly takes 15 to 20 minutes. So this is an animation video which shows the device being there, which is encapsulated into this capsule. And this is the sheath made of PTFE, which covers 60 centimeters of the first part of duodenum. And you see that once you deploy, the duodenal part of the stent opens and the pyloric part. So I'll just show you the same thing in the human model, how it looks. As you can see on the screen, the capsule where it opens up, the duodenal end opens up, and then the pyloric end opens up. See, this is snugly fit here. And then you have a PTFE sheet, which is seen as a white color on this. So as the person eats, it prevents the absorption of the nutrients in the mucosa, and that leads to all the mechanisms what have been told. So, and retrieval again is also pretty simple, hardly takes 10 minutes. The same thing, you have a device inbuilt which enters through, you have a lasso here, which will first make the proximal part of the stent collapse in the stomach, and then the distal part. So this is how it looks. So short of time, I'm just trying to run the video fast. So as you see here, it will catch the lasso, the whole stent collapses and then gets into the capsule, and you just have to pull it out. It just takes 7 to 8 minutes max. So with this, we have published the initial results where we found around 1.8 to 2% HbA1c loss with 12 to 13% weight loss. But not everything is as rosy as it is, because it is all the startup devices. You have a lot of hitches and glitches. So what happened is there's an issue of migration of the device into the small intestine. So as you see here, the anchoring device difference between the Metabolomics and the GI dynamics is that it has got a bifline stent, which we thought that it will prevent the migration inside and it will act as an anchor. But what happened, when the due course when we saw is this pyloric part, it's when the person eats the food, it's such a dynamic organ. I think probably this is the most dynamic part of the whole body in the GI tract. There are a lot of propulsions which are happening, and because of this, the food is being is pushing this part of the pyloric area, and eventually that's leading to migration of the device inside the small intestine. So with this, then we thought what to do. So then what we thought is, let's do a physiological study on the pylorus mechanism and then try to modify the device. So with that, we took the functional luminal imaging pro, the flip, endoflip, and then we have taken healthy volunteers and studied the pyloric physiology. So with this, we have made some changes in the device, and then we thought let's do a suture T-tag which acts as a tether to prevent the migration. We also came up with a long overtube which will sit at the pylorus so that it's easy to deploy. So with this suture tether, I'll just show you in the video. So what we are now doing it in the next phase is, we are going to put a T-tag, one on the pyloric end and one on the duodenal end, and which will be anchored with a nylon kind of suture. So what it will do is, it will prevent the migration and then it will hold the device tightly. So this is the upper part, and the same way the device will come and then do the lower part as you see here, and this is how it looks. So this hopefully will prevent the migration, and of course we have made the device a little modifications based on the normal pyloric physiology. So this is how it looks. So, and we just this is an animal model which we have done in Minneapolis, and hopefully we will be through in this to prevent the migration. The second one, which is a space occupying device, is of course we all have seen earlier, the endoscopic jejunal-ileal bypass and duodenal-ileal bypass. So this is again we have to see how it evolves. This again requires two persons with two ends. One is the oral end where you have the antegrade enteroscopy, and from the aboral end you have the colonoscopy. So this is just a magnet which is being deployed at the jejunal-ileal junction. So as you see in the animation, so this is how the magnet is put, and within 6 to 7 days there will be a natural fistula between the jejunum and the ileum, which will make the food to bypass, that leading to the ileal break, the physiology what we discussed earlier. This again a publication from the Christopher Thompson group which showed 1 year data. So just to summarize from the DJLB, that is duodenojejunal bypass liners, so you have a good glycemic control, you have a and further indirectly to the weight loss of around 13%, and the cardiometabolic improvement, which is what we want, that is improvement in the NASH and also the lipid profiles from the cardiology perspective. So this looks very promising. Just 3-4 minutes on the two devices. The Valentex, which is again way back in 2015 has been described. That's again esophago-gastro-duodenal long stent, but only thing is there are some hitches in this because people perceive to have a lot of discomfort at the GE junction. This is one study which is published in 2015 which showed mild improvement in the glycemic control as well as the weight loss. This is again the courtesy from Barham. His group is working in Mayo on a non-heat technology. I am not going to talk on DMR because Manaval is going to address on that. So once you understand the DMR technology, then you will understand why Barham and group is going on this non-heat technology. So hopefully let's see how this evolves, and then we'll have a good answer on this. So just to conclude, the futuristic, what as Barham told, the physiological thing. So you address two things, the gastric and small bowel, and you try to replicate or kind of give a replacement to the bariatric surgery where you have addressed the gastric part by remodeling it and the small intestine part by covering it and then addressing the physiology. So that's where you will have the obesity, diabetes and metabolic, the cardiometabolic disease being addressed. So hopefully with this background of the novel devices, let's hope that we will give the best to our patients or the obese population, and then we look forward for a positive results in the future. Thank you.
Thank you. Thank you, Rakesh, for showing us all these novel devices. I hope Lopez now is ready, then we can go back to him. Lopez? You're ready with your screen? Yeah, okay. You're on now.
lot of work and effort to organize this webinar. Besides this, in this time that we are having in this pandemic situation. So yeah. Obesity is a disease. Obesity decreases life expectancy and leads to a poor quality of life. If we take a look in this current COVID-19 pandemic, this has proven once again how vulnerable are obese patients and how their mortality is increased. So we have to treat. It's a moment to treat to this silent and this silent unattended pandemic. And how to treat this pandemic, which is called obesity. The traditional obesity treatment has always been diet, lifestyle, sometimes helped by pharmacotherapy. And when this doesn't work, with no other bridge to help the patients go from non-invasive to invasive treatments, we offer them surgery. We offer them surgery since many years ago, but when we take a look in the last 50 years, despite of advancement in surgical techniques, only few opt for surgery. There is a big gap between the treatment that we should offer to these millions of severe obesity patients and obesity patients in the world, and actually the penetrancy of the treatment, which is only 0.25 millions of procedures done. So there is a bridge there to cross, a big gap to this untreated population. And why the patient doesn't want to get treated, even if we know that surgery is effective? Because of cost, because of complications, irreversibility, or just lack of widespread availability of the treatment. So now we have in fact advanced with the treatments, because we are now able to offer the patients more appealing treatment platforms, like they are the bariatric endoscopy ones. After diet, lifestyle, and pharmacotherapy, we can start to offer them appealing treatments, friendly for them, which are balloons and gastroplasty. And this is bariatric endoscopy. We can offer them intragastric balloon, gastric remodeling techniques, metabolic therapies, and also help them after obesity surgery. We all of us, we know this. But what do we do when we decide to do a gastroplasty, remodeling gastric volume? Remodeling gastric volume is similar to, and we have to thank the surgeons because they show us the roadmap to go through the treatments. So we are mimicking or trying to mimic the gastrectomy sleeve gastrectomy, but it's completely different. When we try to do endoscopic sleeve gastroplasties, we perform a tubular shape of the stomach, we shorten the stomach, but the most important thing, the innervation of the stomach is intact, vascularization is intact, and we just try to play with the volume and the motility of the stomach. So this is very important how different it is. What do we have in the market? We have several procedures like endoscopic sleeve gastroplasty or post procedure or endomina, which are now in the market, and some like endosip, appealing new procedures, automatic, full thickness, maybe more easy to be performed by doctors. I'm going to show you a little bit our experience and what is the moment of all of these techniques in the world. The first one is the platform from Apollo. We call it Overstitch, and this is the one which we can create really endoscopic sleeve gastroplasties by endosuturing. This Overstitch from Apollo, it's a platform that is mounted at the tip of a double channel scope, and we call it suture because we use a suture. We use a curved needle that allows us to do a full thickness bite, and also we have a very nice grasper to get enough amount of tissue inside the system. Here I show you a quick clip of how we do this technique. It's a technique that can be done by one doctor, one assistant. as you see, you need to have the overstitch mounted at the tip of the scope. You have to maneuver sometimes with really impaired vision to go from anterior, greater curve, posterior wall, trying to achieve the pattern this U pattern, which will allow you to create this sleeve shape. It takes around 40 minutes of procedure. No major complications are frequently seen, as you know, and it's quite safe and quite effective. What are we thinking about now? First of all, as we know that the double channel scope is not widely available, we have a single channel option that may suit for the needs of the doctors. And it's a little bit cumbersome, but for those doctors starting with these gastroplasties, maybe this option, it's a good technique to start learning. We published the video in Gastrointestinal Endoscopy 2019, if you are interested and you want to see just this teaching video. What are we working at now? We were submitting for IFSO Miami 2020, but also has been canceled by this COVID-19 pandemic. We were submitting, which is this work, which is now in press, because we wanted to see how endoscopic sleeve gastroplasty, if it was also useful to treat those high BMI patients, which are the ones that more frequently are sent to surgery, and also are the ones that more frequently refuses surgery. So we classified near 500 patients we did in the past 4 or 5 years. We classified them in class 1, class 2, class 3 obesity. All of them matched by 48 years old, and the proportion male and female was quite similar. We took a mean BMI of 44 at class 3 and a mean BMI of 32 at class 1, 37 at class 2. And we saw this. We saw, and we were happy to see that ESG was effective in all the BMI patients, but above all, as you can see here in the green bar, was even more effective in class 3 obesity, which is the most concerning obesity class. 22% at 12 months of total body weight loss, which, as you know, it is an independent of BMI way to measure weight loss. So it shows clearly that it can be even as effective or even more than in other class of obesity. And also, if we remember that achieving at least 10% of total body weight loss is which ameliorates comorbidities or has an impact in comorbidities, here we can see that more than 10% of total body weight loss is achieving 92% of class 3 obesity. All of these class 3 patients were refusing surgery. 90% of them achieved more than 10%. So 90% of them have good impact in their comorbidities. But also we wanted to see if effectiveness is just based on the device, is based on the skills of the surgeon or what. And our surprise was to see that the most important thing to predict success in those treatments at 1 year, balloons, endoscopic remodeling techniques like ESG or POSE-1, we saw that the most crucial part of all of this bariatric endoscopy is follow-up. Time and again, we keep stressing on this. Follow-up is key for success because as you can see here in the slide, the more total body weight loss achieved is related with the higher attendance, the higher commitment with the follow-up team. This has been published last year. Also, many people want to compare endoscopic therapy with surgery, which I think is not anymore a moment to compare. It's something that patients decide that even if we offer class 3 obesity surgical solutions, maybe they will refuse it. And if they refuse it, we have to keep on looking for any solution for them. But if we compare, we wanted to see, and has been recently published in Endoscopy International Open by Ravi Shankar Asokumar and Mohan Babu, that okay, surgery is more effective, 30% compared with 17% of total body weight loss at 1 year, but has a price. And this price is this adverse event rate, which is very higher at surgical options compared with endoscopic ones. And also GERD, it's very important because near 6%, there are other series that even they have published greater rates of new onset of GERD symptoms, 6% compared with 0.4% only in the endoscopic treatment. So this comparison, I think it's important. What do we try to do when we start doing any technique in bariatric endoscopy? First, we want to, of course, help the patients to deal with diets and lifestyle change. And for this, we need to decrease hunger and increase satiety. To understand this, we thought that to decrease hunger and increase satiety, the best thing we can do is try to make the food stay longer in the stomach or create a gastric retention of this food. That's why whenever we apply, for example, endoscopic sleeve gastroplasty using sutures, we let an upper gastric pouch at this level. And also when we are creating the sleeve, we create a small gastric pouch for food to retain there. Trying to study in depth, we also perform a gut and metabolic hormone study to see the changes after endoscopic sleeve and compare also with the changes in those hormones that we can see in laparoscopic sleeve gastrectomy. In this slide, we can see, for example, first the hunger hormone ghrelin. We can see that remains at baseline and doesn't go up after the procedure. For example, in patients losing weight after diets, ghrelin has a compensatory increase, and that makes the patients after diets to remain or start to be more hungry and regain weight. In ESG, after ESG, we don't see this compensatory increase in ghrelin after losing weight, which is a good thing. If we take a look in insulin changes, Barham just commented also a few things about this. After ESG, first of all, our patients, all of them, they show some insulin resistance. This is the dotted line where normal reference values are. So our patients pre-procedure are with some insulin resistance, a high insulin secretion, also in the laparoscopic sleeve side and also in our endoscopic patients. But what we see after the procedure is that the pattern of the curve comes to more physiologic one, and we see a very high increase, a very high decrease in this decrease in insulin resistance after endoscopic sleeve gastroplasty. And in comparison with surgery, we can see that the improvement in insulin resistance maybe can be achieved more by endoscopic means, and we are sure this is just because food, gastric retention of food, stays longer in the stomach. And for the same reason, in this slide, if we see the changes in integrins in GLP-1, we can see that after ESG, there is no change, there is no peak. There is no secretion of GLP-1 compared with a baseline curve in pre-procedure, because the food stays longer time in the stomach. This is, again, absolutely different, the changes in GLP-1 with surgery and with bariatric endoscopy. But again, we have the problem, which is common in all the gastric modeling techniques that we have. Are effective, they are safe, but maybe they don't last enough time as we wanted or as we expected. And also, what do we do with those patients regaining weight or not achieving enough weight loss? So, in this paper accepted in surgical endoscopy this year in 2020, We put in 3 groups. Those patients that we had a weight loss failure after these procedures, those patients with weight regain, and those patients with weight plateau. And we saw that, first of all, the patients here, we include 35 patients. We saw that endoscopic gastroplasty redo of the procedure was very easy, was done near in 30 minutes, unlike surgery, where the second surgery is usually complicated and extensive. And at 4 months, all our patients continue to lose weight, as we can see here, even a little bit more in the weight regain group, but all the patients, after the resuturing, they lost weight. So maybe this is why bariatric endoscopy is repeatable. In order to address what is now the most important concern in all the endoscopic sleeve gastroplasties, or in all the gastroplasties that we perform, is we have to achieve longer and more durable treatment. So in order to develop long-lasting gastroplasty, the idea was to create serosa to serosa apposition, which is very durable because we create here fibrosis after serosa and serosa trying to heal one each other. We create the bridges of fiber that makes this plication very stable. And this is what was the hypothesis of this procedure, also very world famous, which is called POSE. With POSE, with this platform, we try to do plications of 3.3 centimeters, 3.6 centimeters, so it will be a plication of a length of 6.6. These plications can be applied inside the stomach to remodel the shape of the stomach by shortening, by narrowing, trying to create tubularization. To do this, we use this POSE platform from USGI. In this platform, you can have these graspers, these jaws. You can have, again, a helix extractor. It's called a helix to grasp the tissue. And we have this kind of sutures to maintain the plications in place. In our past experience with POSE 1, creating this plication, we apply the treatment just in the fundus to try to collapse, and we aim the gastric accommodation and trying just to collapse the fundus to avoid gastric accommodation. The treatment was effective. We achieved 14.9% of total body weight loss. Other randomized control trial with the 34 patients, they show also they were effective, but however, the randomized study with less extensive follow-up protocol, maybe a strange design for the whole bariatric endoscopy approach, didn't show effectiveness and did not meet the FDA recommendation. So this procedure, as the platform was creating a stable and durable plication, this procedure was modified. Many people on board working to modify this with the idea to shorten and narrow the stomach, targeting now the gastric body and not anymore the fundus. And this was, I have to thank to Barham Abudayev. He was thinking a lot of this in Mayo Clinic, and then we did cases together along with Manuel Galbao. Then we started a multicentric trial, and then we started to do this new procedure, which is called POSE 2, with the goal to narrow and shorten the gastric body, reduce the accommodation of the gastric body, not the fundus, slow or impact in motility to impair gastric emptying, so we can achieve early satiety, diminish hunger, and reduce meal volume of our patient. We published a video also this year in 2020, a video showing the pattern along with Manuel and Barhan and Ravi Shankar Kumar with this pattern, and we were happy to. Okay, let me show you here in this video first small clip of how it works, and then we will see the final appearance. Any plication like this one shortens the length of the mucosa from 6.6 centimeters, which decreases the size of the stomach significantly. That's the way we work, and we repeat this. For this post-2 new procedure, we use 16 to 18 plications until we have a stomach completely collapsed. This is the final appearance of the stomach. Completely, if you see this longitudinal axis is shortened by one row, the second, the third, and the proximal one. And as Barham said, here you can see this contrast study where the vertebral bodies, we have shortened the stomach with this plication. And the gastric body here cannot accommodate, and it's very, very short and stable. So at 1 year, we scoped some patients and we saw that the contour remained the same and the plications were still intact. So we are glad to be part of this multi-center study along with Barcelona, our colleagues Roman Turro, with USA, Barham, and my team in Madrid. Also Galbao did cases with us. So we involved 41 patients with a mean BMI of 37, most of them females. With a new procedure, the average time was 37 minutes, and we used 19 plications to try to collapse the whole stomach, creating at 9 months, we are achieving results near 18% at 9 months. So we are sure that if our patient they will be achieving close to 20%. This 20% total body weight loss has been achieved with other procedures, but the good thing is that here we think that results in long term, because of this durability of serosa to serosa position, will last longer. So we think that the main difference with this procedure maybe could start to appear at the second year of follow-up of these patients. All plications were intact at 6 months in the 3 centers we tested. Gastric empty was changed and interfered in 85% of the patient. We saw improvement in fasting and postprandial score, and also improvement in liver fat test and quality of life of our patients. Personally, and this is our results, and I have just last minute included this slide because we don't really understand what we are doing in motility, at least in my center, because we are not that good at all the physiology labs to do this. But in our results, we have seen that 68% of our patients with this pattern, we delay gastric emptying, maybe because the food remains in the fundus, but in 23% of them, we do the contrary. We do 23% of them, they have accelerated gastric emptying. Since we started with performing a post-2 in the trial, then we started our commercial cases in practice. Till today, we have performed 83 patients with some of them 32 has reached 1 year. And those are the results that I'm showing you here, how in a mean average total body weight loss that we achieve at 1 year is now in a mean of 22%, with no major complication requiring surgery that occur. If we talk with the patient, what do we do with post-2? They say they have a reduction in hunger, and in a subjective scale, they say that 50% reduction in volume of food intake is what they see. So this is a new procedure that we aim to see what happened in a second year. And to finish, I'm going to talk to you about one procedure that maybe is going to be appealing for some of you who are interested in bariatric endoscopy and you are starting and you are concerned about your learning curve. Some procedures may take longer time to learn, they are not easy, or they are in it depends a lot on how are your background in endoscopy and how are the surgeon skills. So the idea is to create endoscopic Gastroplasty's platform to be fully automatic, which maybe will increase quality compared with man-made sutures, but also will be more stable and more easy to learn. And this is what we are starting to work and develop, very actively developing with this Israeli platform called Endoscopic, which is an automatic suturing. It's a bougie that based on vacuum, you put the tissue inside a scope, you pass an ultra slim scope through the bougie, and then automatically it's going to have 8 automatic engines inside. So you will press a button to deploy an helical needle, a button to cinch, a button to release the suture, and then you finish. Let me show you an animation. And then I will show you results. Based on suction, we put the tissue inside a bougie. You don't see anymore, but you guess that the tissue is inside the bougie, and you deploy a helical needle that allows you to do a very stable and very symmetric suture. Then you remove the needle and the system, and you have created a very, like a zip there. Okay, like a zip tissue. Those are the images of the first in-human study we performed 1.5 years ago. I'm going to show you the results, but those are the images of the post-op images. How you can see in some of them, the sutures look very nice. You can do remodeling of the stomach, aiming greater curve or aiming, it depends, because it's the device is evolving, and it's going to allow us to select a little bit more the pattern of what we can do. Those are the results of this first in human study published in Obesity Surgery last year. This is a feasibility study that showed that good safety and weight loss result at 6 months in all the 11 patients that we did. So maybe this is a good idea, but the device is really evolving a lot to be fully automatic, which is the aim of the procedure, to create very, very easy to perform endoscopic gastroplasties. And to finalize, I would like to talk about what are we doing in bariatric endoscopy in terms of changing patients' life. Changing patients' life, it's what at the end is what we need. And we have seen with all of these health and quality of life scores that we are able to change physical, mental health, some social function, emotional roles of the patients before and after bariatric endoscopy. So we have to measure all of this, not only in terms of weight loss, but we also have to try to measure the results of these procedures on quality of life, which is ameliorating these categories, for example, but also not creating any complications. So the patient start to be familiar with treatments for this chronic disease, and we will be offering them different steps. In conclusion, and to finish, endoscopic gastroplasty, all gastric endoscopic remodeling techniques are safe and effective. So no more discussion are required on its role and its time we offer to patients because they look safe and effective. The future is offering systematic sequential endoscopic therapy because we are talking about a chronic disease that is going to need no way to think. On the contrary, is going to need several steps for this chronic treatment. Understanding physiology, patient's trait, genetic trait, motility of every patient is required to personalize treatment option. This is going to be very important because we have now different treatments with many options, so we can decide based on how different are physiology of our patient. Training more people is key in scaling in bariatric endoscopy and tackling the obesity pandemic. We are happy to announce that we are going to create this MIBE Academy. Is going to be inaugurated in 2 weeks, not for lecturing or giving courses, but to really teaching on site or virtual teaching in this term. Will be MIBE Academy. Many selected faculty and doctors are going to be involved, and we will be announced. Thank you very much.
Thank you, Professor Lopez Nava, for that very nice talk, very extensive talk on different modalities of gastric remodeling and how the results show our effectivities. We now go to the last talk of this webinar, and again, I'm extreme pleasure to introduce Professor Manuel Galvo Neto. Manuel is also one of the pioneers in bariatric endoscopy. In fact, he started as a surgeon and then became a bariatric endoscopist, has devised many new devices and been responsible for publications in many new areas. We're extremely glad to have him here on this panel, and he's going to talk to us on metabolic endoscopy, an area which is very promising, very exciting, and all of us are looking forward to this. Manuel, thank you very much for being with us.
Thank you very much, Nagi. I wanted to personally thank you, Rakesh, for having me here. Thank you, Braham, also for the invitation. I'll just gonna share my screen with you guys and go directly to my presentation, that I hope you have it right now on the screen. So I'll talk the harnessing the small bowel physiology give us, the possibilities or the opportunity they give us to interfere with some metabolic disease. This is the persons that I work with that probably allowed me to do my job. And we also have saw here how it goes when diabetes merge with obesity, creating the diabetes. When they come in the path, we already had saw the damage it can make. So diabetes, this global epidemic that is all over the world, it's not just this, it's just a metabolic epidemic. As you can see here, just check the NAFLG, the first reason us to do hepatic transplantation pretty much all over the world, that goes over virus and goes over alcohol, as we saw recently. Also, like polycystic ovarian syndrome, you can see here, is prevalent in so many parts of the world. They are all metabolic. We pretty much have saw all of these is in the bariatric therapies on the bowel. Just check, they are still experimental, and I'll pass to the ones we know the most, and they'll have more publications. But let me tell you this, that the bowel gives us the opportunity to understand the metabolic disease. And I'm just gonna get back to you here with this slide of Francesco Rubino paper in 2010. And it was kind of with an endoscopic concept. And you can see here that is a Goto Kakazaki rats, so they are they're genetically modified type 2 diabetic rats. And you see here two images. You have one intact sleeve, and the other is a fenestrated sleeve, meaning it allowed the bowel to get in, the food to get in touch with the bowel. And if you see here the graph on the right, you see here that that the rats that have the intact sleeve have a non-diabetic response after, and the ones who had allowed the fenestrated ones, the food to go in touch with the bowel, get a non-diabetic diabetic response. So it means that this is a very strong experimental data showing us how the bowel interferes with metabolic disease, and this is called the foregut theory. Also, we have the hindgut theory saying that if we had food fast enough into the distal bowel, we can have a positive impact on diabetes. So this is also a very emblematic slide that from a study of 2013 with the duodenojejunal bypass with the sleeve. And if you already have saw a gastric bypass GLP-1 response, you're gonna immediately identify the same curve. They are pretty much the same curves, not as powerful, but it is. So you have here the area under the curve when how the GLP-1 increases in human patients. So we can see here. So with those, we can begin going to the device. The one that we know the most, and Rakesh has introduced us, is the GI sleeve that produces a duodenojejunal bypass. I'm just going to show you the pictures to save some time. So what we do an endoscopy, we guide wire, then over this guide wire, we slide the capsule. Inside the capsule, like a parachute, we have a 2 feet, meaning 60 centimeters, PTFE sleeve that we will extend into the bowel, have a traumatic bowel that we release the bowel, then we rearrange this capsule into the stomach. And in a post-pyloric situation, we deliver a stent with 20 barbs, 10 proximal, 10 distal, that's going to fix in place this sleeve. How we're going to work, just go to the right of this slide. You're going to see the fluid will pass inside the sleeve, and the bilipancreatic juices and secretions will pass alongside of them. They will mix 60 centimeters after the pylorus. It's pretty much what a bilipancreatic limb of a gastric bypass does. So when the time comes, is around 1 year, what we do, we have a customized cap, a customized grasper. So we get the suture on this anchor, proximal anchor. We grab it, collapse it, protect with the hood, and then we remove, as you can see here on the picture on your right side. So that's it. Let's go for how it works and the results. So there's at least 30 well-designed studies about this device, and let me guide you to this graph. So it's a 4 quadrants, and if you see here in the upper left quadrant, you have patients that only drop H1C. On the upper right quadrant, on the other hand, you have zero response, no response. So the inferior right quadrant, we have the ones who just lose weight, but just get the concentrated dots, meaning the patients that respond. This inferior left quadrant show us an effective drop on H1C, an effective drop on the weight around 10%, and around 1.5% drop on the H1C. Also, if we just get to the weight, and we see here the studies done in Brazil, study done in Chile, we have the opportunity to do the very first in human procedure in Chile, and then in Brazil we did initial results, and it go to Europe with multicentric and RCT trials. But just check here, they are below 15% of total weight loss, the longer studies. So, Gotran, you should mute your mic. Gotran, mute your mic, please. He's not listening to me.
Se me veía mirando.
Mute your mic. Can you guys mute his mic? Please. Thank you. So we studied so much this device. We developed so many studies that ASGE, led by Braham at that time, make a very interesting studies they do in US to evaluate devices, a gastrointestinal device that is called PV. So what this PV means, they put all the papers together, they put it on a chart, and they decide what paper should be analyzed or that on technical skills. And you can see here that those studies that you can see follow from 3 months, 6 months, and 1 year. And if you see here the losango is when we meta-analyze the data, and you go to the inferior right quadrant, you're gonna see here that is H1C. So to the left is a drop on H1C, to the right is an increase on H1C. So you see here that very consistently, those non-randomized studies point to a drop of around 1.5% of H1C. And even those 3 that I'm showing now to you on the screen, there are 3 randomized control trials. And again, when we randomize them, you see the losango, the red losango goes to the left, and we have positive impact on H1C. There is, it's any device that we implant, we expect to have some adverse events. Most of them, they were temporary in the beginning, pain, nausea, vomits. Then it comes migrations, bleedings, blah, blah, blah. You can see here very slow incidence of sleeve abscess in Europe and Latin America. And also, we have the opportunity with this device to have some very interesting studies like that now is a trend that is adding drugs to devices, drugs to surgery. So it's one of the very first that mixes liraglutide with gastrointestinal device was done by NIH, NIHS, in UK. It's very, very easy to understand. So we have 3 groups. One group of endobary and liraglutide 1.2. And then we have endobary no liraglutide, and we have liraglutide a maximum dose 1.8. So we have 1 year then, and it was a randomized study with the second year of observation. So very, very easy. On the left, we have in blue device plus drug with a very good impact on weight loss, you see in blue, and also a very dramatic impact of 2 points drop on H1C if you see going to the right. And then you see in pretty much in orange just the device, and then in gray you see the drug. Also, they could calculate in some mechanisms, some softwares that they will have future impact on lowering the cardiovascular events on that. So this device presented to us a glycemic control of around 1.6. There are around more than 10% of total weight loss with a good metabolic impact on that. And then, as all the devices happens, they went to US and they went to an FDA trial, meaning there is a sham-controlled randomized trial with around 300 patients on therapeutic arm and a half of those on the sham group. But unfortunately, for a very unexpected rates of a specific adverse event, that is the liver abscess, that you saw that was so low in rates in Europe and in Latin America. In US, it reaches 3.5%. So the study was stopped by the FDA and for safety reasons. That said, even if studies that have stopped, let me show you the interim analysis of the data that we have before it was shut down. So in red, you see the sham group, and in blue, you see the therapeutic group on that. And you see, again, it's the same graph as shown in the beginning. The inferior left quadrant are the ones who lost weight and have a good impact on H1C. You can see the concentrations of the blue dots, meaning the therapeutic group on that. So it could prove super superiority even with just a third of the patients enrolled. So ends up that they get back to the FDA, they redesign the protocol, they got a new chance. So now they're under, again, an FDA study. We have to see how it goes on the near future. You can see here the official allowance to go into the trial. So it pretty much cover all of the literature we have, and we expect the device to succeed because it's a very good. So Rakesh showing us a very good alternative. So there's the balance when you're dealing with duodenum. So you put something that doesn't dislodge but can harm the patient with like barbs. And now you see no barbs, no harm to the patient, but they will dislodge. So you have to go up like with a very good option that Rakesh team has of putting that some kind of suturing on those. So the next one is the thermal mucosal resurfacing. And thanks to Braham, I have to change the name of these because we just saw the duodenal mucosal resurfacing. Now we have high frequency, we have thermal, we have laser. So it goes one and one, but let's see the thermal one. And the idea is that the mucosa of duodenum itself is part of the genesis of diabetes. And if you just recall that a few years ago, the mesentery was identified as an organ. So we're pretty much on the way to identify the mucosa of the bowel by having a major role in metabolics on that. So the idea comes, and you see here that this is not published, but was done by the company, is that again, our very well-known partner, they go to Kakazaki rats. So you can see here that they mechanically ablate the mucosa of the duodenum and wait. And you can see here on the small graph on the inferior left quadrant that you can see here a non-diabetic response on the ablated duodenum for those. Then, as all this device goes, we went to the pig models to assess safety. And you can go here from left to right to have the mucosa intact. You have the D3 of the thermal ablation and then D14. So just go and see the on the microscope, D21, 28, and look at the D42. The mucosa is like hairy, but it's there for sure. It's a mucosa. And it's different. So we end up going to the first in human trial again that we published in GIE. How the technique is. I'm gonna show you again in pictures. So it's like this. You use a pediatric colonoscope. You identify the papilla, tattoo the other side or put a clip, and then you go up to the triangle, your guide wire. Over this guide wire, you can see here on the left, is a very special balloon. And this balloon will be inflated with water, will touch the mucosa in 3 spots. And you can see here on the right part that on detail, we're gonna aspirate the mucosa, and then we're gonna inject 10 cc's of saline solution with methylene blue. And we're gonna do 2 lifts, and then we're gonna ablate how we will have circulating hot waters at 87.5 degrees for 10 seconds. So 2 lifts to an ablation, 2 lifts to an ablation, and we go in the direction of the triangle. Our goal is to get it to at least 10 centimeters ablation on that. So you can see here, again in pictures, from left to right, you have a pre-procedure, then you see everything is blue and lifted to 160 degrees very beautifully. Then just after the ablation, and in 3-month follow-up, we have pretty much a normal mucosa, meaning we have ablated just the mucosa. And I'm gonna show you here a very brief video. This is the setup. So we use X-ray, we use endoscopy. So we have the both images. This is the balloon in position. Then we're gonna blow the balloon with hot water, and we're not gonna see that because we need a perfect seal with aspiration around the balloon. But just look at after we finish. So it's really, really pretty much damaged and lifted, as you can see. And 1 year after, this is how it looks. So as any device, we begin with 89, 96 minutes, and then you see here a huge drop of 45 minutes of to do the procedure with the new design balloon, and we expect that they can develop even better on the design. Question: Are we really ablating the mucosa? So this slide, this picture, we will assure you. So just follow me. So we have the screening 1 month and 3 months after. Look at the names. Complete villus formation, no acute inflammation, no chronic inflammation. Just go to 3 months, random biopsies when where the place we have ablated. You can see here that we really have just ablated the mucosa, what is very positive for us. And when we don't ablate just the mucosa, in this case specific, it's my fault. From the very beginning, we thought we are dislodging, we are just overlapping ablations. So we have a stenosis, but you can see here it was very easily treated with CRE dilation, balloon dilation. So then we go on the publish the first in man data, and what the first in man data have, it was published in Diabetes Care. So you can see that this specific group of patients, they were out of insulin, so, and they have a pretty much diabetic group, as you can see here on the screen. So our results, the preliminary, so we developed the technique. You saw here on the left that we have 2 groups, that we have long ablations, small ablations. We were adapting the technique, but we have a drop on H1C, and some of the patients, they recur. So we have to establish and refine the technique to get to the other one. Interestingly, we did this study of metabolomics, and I'm sure that Rim, Braham, and Gortan will recognize that better than me, because it's very complicated and sophisticated. But just go to the bottom of the slide, and they show that it lowers the lipotoxicity stress and lower the glucogenic drive on that. So it's a very, very elegant study done. And then we also have this dramatic improve on the mixed meal tolerance test for glucose. And you see baseline in red, and you see the dramatic result in blue in 1 month on the continuous graph, and also on the area under the curve graph. So we got on this. So again, we go and we're gonna play with upper right quadrant H1C, upper left quadrant, upper right quadrant, the fasting glucose, and down below on the inferior left quadrant, the HOMA-IR drop, meaning the insulin resistance, and also you see here on the right inferior that the BMI basically doesn't change, so pretty much a metabolic disease. So then we go to another studies called Revita studies, and now is a multicentric between Chile, Brazil, and Europe. So you see here 24 patients, and you see here better results when the patient follow for 12 weeks. You see a drop on H1C that comes stable, and the HOMA-IR drops on that. Also, we have the opportunity to study the impact of this on the liver, and it's very preliminary, but very good one. So look at the drop on LOT and the absolute MRI PDD-FF. What this means is the fat on the liver drop on the patients that have fatty liver or NASH. You can also see here more blue, meaning less fat, so we can check the effect on those patients that were reacted. Here's pretty much the same. You can see in the graph the MRI fat fraction go lowering on those patients as the H1C also drops. Then to present this data is a very interesting one. So the Revita 2 is a prospective randomized sham control study, but it have a lead-in part, means that's not randomized, it's more to everybody to understand the technique. And this is the results of the lead-in with a drop rate H1C from 80.4 to 7.4, and a dramatic drop on the HOMA-IR and LAT. And it goes and evolves to the publication of this in gut. So you can see here the drop of H1C around 1. From 24 weeks, it keep up to 12 months, and you see how it drops and slightly regain when you go to 1 year. Again, the same 4 quadrants. You see upper left, the glucose, upper right, you see the weight, how it's a very little and stable. Inferior left, the HOMA-IR, and inferior right, the LAT. So it's a very interesting how dramatic is the results on the liver on that. And we have some RCT, some randomized control, sham control. That is the top line of this study that was presented on American Liver Disease Association. And you can see here that it was a significant drop with GMR with compare H1C to the sham group. And also, if you just get the responders on the right, you see a more dramatic response on diabetes. So what we have now, and what I can tell you, that the FDA trial pilot have already studied, and it's gonna be a big trial as the one for endobarrier, so we have to wait for the results that will come. So that's pretty much what we have covered. And then we're gonna go on the jejunal bypass that Rakesh just showed something to you. It's not a new idea. So magnetic anastomosis is done, you can see here a slide of 2009, and another slide of 2009. And let me tell you this, on the left is a experimental case in the pig, and on the right is a human case in 2009. We went down the road quite some times, and were studies, so it's a very rudimentary and preliminary. So we have this magnet, is a pig, as you can see, pig model. So we deliver the stomach magnet. And then we will, the bowel magnet 1 meter after the pylorus. Then we deliver the stomach magnet. Look, they are already attached, and we follow at least 5 of those pigs. So look at the exam at day 7. So the anastomosis is forming. And after anastomosis is formed, we use part of the duodenojejunal bypass with the sleeve. We just use the anchor, and we put a stop on that. So you can see here there's no contrast. So look what we have here. We have no passage of the contrast down the road. And you see here that the stomach passes into the jejunum. And even with pigs surviving for 200 days, you see here the anastomosis that is patterned on that. So we've been studying that for quite some time. But now with those very sophisticated magnets for a specific company in US, so you can pass into the endoscopes. And I'll show you here what Rakesh had shown. So it's colonoscope, so you intubate the ileum around 70 centimeters, then you go by the mouth, and what you're gonna have is try to go 50 centimeters after triangle. So you're gonna lie them, go to a drop zone, transilluminate to see each other, use the X-ray also to confirm. Then you drop the magnets, they will go and form. You have like outside like 2 joysticks that you're gonna lie them, then let them go, connect, cut the threads, and let it there. After 7 days, the idea is that they will compress and pass, creating an anastomosis, a side-to-side anastomosis. And you see here from the left to the right, very on the inferior part, that's not what had been done previously by surgery that should not be done. That's end-to-end and a side-to-end anastomosis. So it's a partial and it's a side-to-side anastomosis. So Rakesh showed you the study that was published. I'm going to show you some of the results. These patients now, they are followed by 3 years, and you see the fasting glucose in light yellow and in light blue. You see here the reduction on the diabetics and the pre-diabetics patient. Weight loss 1 year, almost 15%. Those patients, they were followed for 3 years, gentlemen. They reach now 18% of total weight with not a single one regaining weight. Diabetes under control with 1.8 drop on H1C. And at the end of the very third year, they have 1 internal hernia. And this is the Achilles tendon, one of the Achilles tendon of these techniques. And you can see here how we deliver the magnet and the lumen on the left, and on the right by safety. On the trial, we need a laparoscope to confirm that magnets were coupled. But get this on the next slide. You can see here that you cannot even tell where the anastomosis is because it's so beautiful, well formed with no inflammation. But on the right, you see the side-to-side anastomosis. But there's always a but. And I can see that Braham is just looking at me to see what is the but. But it's very hard to do it. So it's a 3-4 hour procedure. You need some of the most experienced endoscopists in the world to do that, because getting to the delivery zone and drop it and align it was very, very difficult. So I ended up that we went to the Argentina to do a randomized trial. The trial, you see that the very first case were pretty much fully endoscopic, but it changed. So go back to the lab, change it. How it was changed now is a lateral endoscopic procedure. And it starts by laparoscopy, you see on the left. So do a laparoscopy, identify the ileocecal valve, and grasp the ileum from that 250 to 30 centimeters. And then the surgeon gonna pull it very near, not to the jejunum, but to the duodenum. And by endoscopy, we got into the duodenal bulb, open up the magnet, and then the surgeon will pinch the bowel, open up another magnet, align it, the pinching or the puncture site to get inside the magnet area, so attach them together. And again, I just have to wait to form the duodenal as some of the bariatric procedures we know they do it. So you can see here some of the human image, so how the magnet is being deployed, forcing it into the duodenum. And on the right side, you see the ileum with the duodenum and the radiological. So they have done around, before the pandemic, around 5 cases. The results are doing very good. Drop in H1C, drop in weight. Let's see how it goes, so how it cover. And I'm about to end, show you just a glimpse that what we have done. So you can just get to yourself. Well, the nasal bypass since 2005, around 4K, because it was, for some time, it was commercially available. Around 12, 13 total weight loss, a good drop of H1C, 1.5 to 2.5. Have up to 5-year follow-up published on that. And the adverse events up to 3.7, more than 30 articles, 3 RCTs, 3 meta-analyses. DMR, 500 cases done experimentally worldwide, just very small total weight loss, H1C 1.2 and 3 and 1.5, some studies, small studies, 2% drop, up to 2 years follow-up around 1%, let's say. And the bowel anastomosis, we don't have much experience. This is the one that we have here. And agreeing with all my colleagues, we are getting to a point that we can mix techniques, mix with drugs, and get to the next step that I'll finish with what Braham starting. So this is a sleeve balloon, and we are helping them develop. So they just finished the experimental rodent study, and now we are developing the protocol and Also, the device itself, you can see the idea is to put that on the stomach, open up the balloon, then it slides or open up the sleeve into the bowl up to 1 meter. And then we're gonna have, you see on the right, the food getting to that, and you're gonna have components of stomach component and a bowel component that we see in the future. To take it out, we're gonna puncture, empty, and remove that at the end. So we expect to do the first human study on the years to come. So thank you very much again for your patience, and thank you very much for your invitation.
Areas of metabolic endoscopy. We are getting in a lot of questions. Unfortunately, I think we are short of time. So we'll just take 3 or 4. One of the common questions, the theme that's coming in is that a lot of people are asking this confusion about what happens to gastric emptying for ESG versus POS, because I think when Barham first started, he said ESG delays gastric emptying, but POS causes an acceleration. And then we had data from Lopez saying that POS also causes delay in gastric emptying. So this is a question both to Barham and Lopez. What do we make of this data? Should we actually check the patient's gastric emptying and then decide the procedure, or are we still in a very early stage?
I hope they don't fight.
No, not at all. We have done the studies together, and we have made ourselves this question many times. Before Barham will tell you the real answer, we have to say that we just measure gastric emptying the same way we use it with for balloons. So with balloons, we completely 100% correlated what was done with scintigraphy and with gastric emptying breath test done in Mayo Clinic. So in Madrid, we did the balloons. So with the same technique, we apply this for ESG, and we were close to this. But when we started to do gastric emptying breath test for post-procedure, where we found 68% of delaying, at that time, Mayo Clinic has evolved and also has many other ways to measure motility. And so we don't know. We don't know. That's what we get in gastric emptying breath test, and we think we know how to do it because we are out of our learning curve in this procedure. But there are other ways to measure it, image techniques, or maybe the timing at which moment we are doing. This is something that we know, that we are getting different results, and we would love to. I would love to know exactly what's the reason. Barham, you're the clever one.
No, I think it's a very good question, and we studied that at length. And the beauty of prospective studies that they eliminate a lot of confounding. And with the US studies that we've done, the gastric emptying is not measured once, and same with the multi-center, it's measured at 3 months, then at 6 months. And with the post procedure, you see that these plication initially could restrict the stomach to delay gastric emptying, especially at the early time point when fibrosis has not ensued. So when you look at the image of the stomach on fluoroscopy and on gastric emptying at 6 months, when fibrosis has ensued, actually, the stomach even becomes more tubularized and more rigid. And that's when it will speed up gastric emptying. So and some people reach that effect sooner than later. So one issue is the common pattern that we're seeing is initially there might be delay before the fibrosis of the gastric wall, and with time there is a more of an acceleration, and that acceleration at 6 months is what correlated with the responders phenotype at 1 year after this procedure, which is unlike ESG, where ESG is more of a restriction and reduction, and it delays gastric emptying both in the short term, as we showed in the merit, at 3 months, and continue to delay gastric emptying at 1 year. And that's one of the discrepancy. The other discrepancy is, which is we found clearly in the 3 studies, 2 centers, which is Mayo and Technon, were using the gold standard scintigraphy, and Madrid was using the breath test. Now the breath test is spirulina gas that once excreted is absorbed from the small intestine quickly and comes out of the breath, and you could measure it. So this test is validated for gastric delay. It's validated as a gastroparesis breath test. It was never validated for detecting speeding or acceleration of gastric emptying. So when you look at the scintigraphy data, your conclusion with the post-2 is that there's an acceleration. When you look at the breath test data from Madrid, it's a different story, and it's probably, the answer is probably when you measure the gastric emptying, the degree of fibrosis, and the technique that you have used, because the spirulina test has not been validated yet for acceleration gastric emptying. It's only validated for delaying gastric emptying.
Yeah,
And I hope that clarifies this.
I think thank you for that clarification. An interesting question that came up is, again, Barham, this is for you, that is there a relationship between the volume of fluid in the intergastric balloon to gastric emptying? So in the sense that if you fill up less, is the gastric emptying not so much delayed? Is there any studies on that?
Yes. And that actually, there is a study, and it comes from the SPATS randomized trial in the US, where we capitalized on these prospective studies in order to understand physiology. And in the SPATS randomized trial, we took the 40 patients that were enrolled at Mayo Clinic during the trial, and we measured their gastric emptying using scintigraphy at baseline before the balloon, when they had a smaller balloon volume, and we measured it after the adjustment in volume. And what we found is there is an incremental increase in gastric emptying that correlates with the increase in volume, and both of them predicted weight loss. So yes, there is a correlation between the volume, change in volume, delaying gastric emptying, and weight loss. That's why one of the clever strategies for the balloons, which I've been pitching for a lot of these companies, is whether you use Orbera or others, you start with a smaller volume balloon. At the time of removal, you put a bigger balloon and keep it for another year, because you were gonna capture incremental delay in gastric emptying that does correlate with significant more weight loss after the balloon.
Thank you, Barham. And then for Reem, we have a question. Are there any abstracts this time on the learning curve of ESG and POSE at the DDW? And in your opinion, is there a difference in the learning curve between these two procedures?
There weren't any that I could see at first pass. With ESG, there have been several studies looking at that, published by us and also published by the Hopkins group. Essentially, you need about 35 cases to get to a procedure that's under 45 minutes. With the POSE, I think Lopez Nava or Barham can talk a little bit more about that, but there's not been anything that compared the two head to head, as far as I'm aware. But with the POSE device, again, you need about 15 to 20 to get comfortable with the device. Again, you need 2 people to do it, so both need to know about the procedure, but I don't know of any study that looked at the POSE on its own.
Okay.
Do you guys want to comment?
Lopez, you want to comment on that?
Yes, thank you. Well, there is 2 ways to look at the learning curve. One, when we teach some doctors, one is trying to understand what we do in the procedure, what is the final pattern we want to apply. At this point, ESG, it's more difficult, because sometimes the U shape or other patterns that you can apply are difficult to get oriented. And so at that point, ESG is more difficult. But then technically, the movements to achieve the right positioning, or the technique to be safe and not perforate the stomach, for example, which is our main concern, I think is more difficult in POSE. And in POSE 2 is easier than it used to be POSE 1, which was working in everything in retroflexion with the devices. Whenever you pull, you advance, so perforation likelihood to perforate was higher. So let's say technically it's more difficult POSE, but understanding what we do with this plication, it's quite easy. At the end, maybe we can balance and it will be the same length.
Thank you, Lopez. I think Rakesh, we have a question on full sense device. How easy is it to remove this? Because look like the tissue ingrowth is causing problem.
Yeah, so in our experience, what we found it's pretty easy. Even the ingrowth happens, it's very minimal, and once you are able to cut the sutures, it comes out very easy. We haven't had in our short experience any difficulty in removing it.
Okay, thank you. I think finally, Manuel, there is a question which is coming in regarding the metabolic endoscopy. You talked about DMR and other devices. The issue is that you also showed us that after 3 months, the mucosa comes back to normal. So how, what about the metabolic problem? Why doesn't that come back to normal? Because one would expect that if the mucosa is coming back to normal, the glucose control and the metabolic process also should come back to normal. What's the difference between the new mucosa and the old mucosa?
That's a very good question, Nagi. And as far as we know, and studying the microscope and how it goes, the first thing is the clinical effect. So we have clinical effects up to 1 year. And the first thing that comes to our mind is, so mucosa just gonna grow again in like 1 week. So what to expect? So pretty much like when you do a facial peeling for cosmetic purpose, they last 1 year. So this new mucosa that's allegedly or possibly are non-diabetic mucosa, we're gonna have an impact until the drive for the diabetes go there. The beauty of this is that if you just are ablating the mucosa, it can be redone. Also, this type of technology in the future will allow us to, after we do the ablation, we inject stem cells from other sides like the distal ileum on that. So the idea is that as the cost of living with diabetes, especially if you are on insulin, is that expensive, that you can do that each year or each other year, because once you control, it takes time to go and imbalance again around 1 year or so. So that's the idea. But there are many hypotheses how it works. Is the microbiota, is just a mucosa that we are remodeling? So we are about to know now. That's why I start telling you what is happening clinically.
Thank you, Manuel. I think just to know all the speakers that we've had a huge number of audience logged in. We also have a large number of questions coming in, but unfortunately, I think we're running out of time. On behalf of both MCCN and AIG, I'd like to thank all the speakers for their excellent talk. I think we covered the whole spectrum of bariatric and metabolic endoscopy. It's like sitting through one whole day of a symposium on this. Thank you very much, and be safe.
Thank you.
Thank you.
Thank you.
Thank you so much.
Be safe. Thank you.